Absolutely. So I think what's really important to think about when it comes to kind of how we invest in this space is distinguishing between what is clinical utility and then the patient or consumer preference. And you might even throw in the kind of provider preference as well. Now, you could argue provider preference aligns with clinical utility, but those are the kind of 2 to 3 distinct different attributes, right? So what do I mean by that? There could be things that we as patients and consumers say that we believe are good use cases we would like to use telehealth for, right? So I hear anecdotally and read in survey data that patients say they want to be able to do more virtual care with their oncologist, for example, right? And they want to be able to, why do they have to go see primary care, or why do they have to go to the dermatologist, right? Like they're all, why do I have to go to physical therapy, all those things when I can just do it virtually, right? So those are patient preferences. But when we think about the actual kind of clinical utility and even clinical effectiveness, and this is a space where we don't have necessarily formal quality metrics on, but if you think about just the science and the practice of hands-on medicine, some of those things are at odds with what providers and clinicians can do kind of to the best of their ability, right? So, you know, are there certain low acuity kind of rashes that make sense? You can probably flash up on the screen and, get maybe an assessment. Sure. But does that mean that's always going to be effective or the best way? Like, does the provider feel the most comfortable making a diagnosis just by looking at a screen? Or are they going to prefer I actually want to see you and, maybe not touch in a rash situation, but, to swab it or assess it, things like that, right? So I think it's really understanding what is the best practice of medicine, and can you actually deliver the same kind of standard or quality despite what maybe the individual preference may be, right? And I think that is one of the big tension points that we're having in healthcare, because we hear it all the time. Everyone's saying patients love it and they want it, but is it actually what's good for the health or going to deliver the optimal outcome? And those things can often be subjective, right? For some patients, the optimal outcome is just getting a prescription and getting a script. And so that virtual care interaction was effective. But for things that maybe, aren't a simple Z-Pack or something like that, and it requires something more involved, you could probably miss that in virtual care. The provider feels less comfortable being able to make that determination if they can't assess you physically or check your vitals or run labs and do these things. So for anyone thinking about investing, whether you're a provider or, life sciences, whoever you may be, I think it's really important to really consider, teasing out what is the overlap between what are the clinical use cases that really satisfy both, right? And then that's really where one should invest. And so behavioral health is a great example of that, right? We see that, like we talked about earlier, low acuity care. I mean, if you're treating a patient for anxiety and depression, you don't have to do as many labs, and there's less of the physical exam, and it's more of a conversation. And in some cases, there's some studies that talk about it might be preferable to have kind of the screen distance between someone when you're being very vulnerable as opposed to being physically in person with them, right? So clinically that kind of makes sense. We also have supply shortage on the physician side there. So it's a good way to extend capacity, right? And then it's also something that kind of aligns with that physician preference. And then the payment parity piece of that also aligns to kind of provider preference, right? So what I mean by payment parity, it's not the same way we talk about it from a policy perspective, right? Because even though there are certain things that are, you get paid the same, as defined by reimbursement, a patient that goes in to see their therapist or their, psychiatrist, that doctor is going to get paid the same in person or virtually. For primary care, even though in theory that should be the case too, right? You go in, you have a sinus infection or something like that. You go in person, that's a one E&M code. It's the same amount you would get virtually. Well, when you go in person, the provider can also swab you or, run a quick blood test, right? So those are ancillary services to actually render or treat the patient. Those are additional codes that you bill. So the net or the total reimbursement, I should say, for that visit is actually greater in person for that one interaction than it would be virtually, right? And that's kind of what I mean by payment parity. And so that's another dynamic to kind of factor in, between clinical utility and patient preference. So long-winded way of saying there are very few clinical use cases that really satisfy all those criteria and that kind of Venn diagram overlap, if you will. And that's really what I would encourage all, those who are wanting to invest in this space really think about.